I can get started. So welcome everyone to the Urban Research Seminar today. We're welcoming Dr. Gregg Gonsalves today. He is a global health activist and epidemiologist here to speak with us today about the coronavirus, HIV, and activism. Dr. Gonsalves is a Yaley through and through. He received his bachelor's from Yale College in 2011 and followed it with a PhD in public health from the Yale School of Public Health in 2017. He's now an assistant professor in epidemiology at the Yale School of Public Health, and he's also the co-director of the Global Health Justice Partnership. This is an interdisciplinary initiative between the Yale Schools of Law and Public Health to further advance human rights and social justice perspectives in public health and legal research. He's also a genius. He, in 2018, received the MacArthur Foundation Fellowship, which is amazing, right? His work is designed to give politicians and policymakers the information they need to make better decisions for public health. He has used quantitative techniques to address deficiencies in the provision of care, largely for HIV. He's created mathematical models to help make public health policies evidence-based. For example, he's determined methods for hotspots for HIV testing to maximize identification for undiagnosed HIV positive persons, as well as ways to minimize dropout of HIV positive patients from care. Recently, his work has looked at the intersection between HIV, hepatitis C, and the opioid epidemic, which is very timely as well. These are just a few examples of how his work has looked at improving the response to global public health challenges and optimizing the effectiveness of health programs for epidemic diseases, particularly for poor and marginalized communities. Dr. Gonsalves has also been an HIV/AIDS activist for, I think, about 30 years. He's worked to connect HIV/AIDS communities with researchers and scientists to advance scientific knowledge of the disease and expand access to care. He's worked with organizations such as the AIDS Coalition to Unleash Power, or ACT UP, and the AIDS and Rights Alliance for Southern Africa. He was also a co-founder of the Treatment Action Group in New York in 1992, which focuses on research and science related to the virus. For this work and more, he won the inaugural AIDS Leadership Award from the John M. Lloyd Foundation in 2008 for the role he played in international efforts to accelerate AIDS research and improve access to life-saving drugs. He is at the intersection between human rights and public health research and practice. His experience as both a community activist and his expertise in quantitative analysis and operations research modeling make him uniquely qualified to speak with us today on how we can fight the coronavirus pandemic and successfully secure the public health of the country in the wake of this pandemic. So with that, Dr. Gonsalves, we welcome you to our virtual space today and look forward to your presentation.
So I'm very, very happy to be here. And as a New Yorker in exile, as Jacob knows, I wish I was there with you in person. So I have a little bit of a schizophrenic academic life. Part of it is work that's quantitatively based, thinking about the health of people who use drugs, particularly the intersection of substance use and infectious diseases. The choice today was whether I talk to you about that or I talk to you about some of the other work that I do at Yale, which is really centered a little bit closer to the law school and to the work I do with my colleagues Amy Kopczynski and Ali Miller there at the intersection of social justice, human rights, clinical medicine, and decided I'd focus there because of the crisis we're in right now. I'm going to talk you through some of the work that Amy Kopczynski and I have done over the past few months in essays for the Boston Review, which Amy and I are trying to put together into a book right now. But then towards the end, I wanted to sort of, well, you'll be the first people to see it. So we've been doing some work with the Center for Spatial Research at Columbia with Laura Kurgan and her team about taking some of the ideas that Amy and I talked about in our essay, The New Politics of Care, and putting it into sort of spatial terms about what vulnerability means in the US and how we might address it across the American landscape. So I didn't, when we get to the end, I'll share my screen and show you the website we've developed, but I just wanted to talk through the issues that come through our pieces in the Boston Review, and want it to be more conversational and people can interrupt and disagree. And it's riffing off of a lot of the topics in the 3 essays that Amy and I wrote in the fall, thanks to Josh Cohen, who asked us to do it. So I don't have to explain the enormity of the pandemic to people who live in New York. You're at the epicenter of it in the beginning, and even if it's exploding around the country, New Yorkers were at the heart of it for many, many months and weeks. You know, what I think we all forget is the enormous generosity we've shown each other for the past few months. We're all getting tired of sitting at home and sitting on Zoom calls ad infinitum, not seeing our friends and family, but we've been all engaging in an enormous act of generosity over the past few months, doing things that that we thought would have been impossible in order to sort of protect others. But the question is, what are we doing to protect the most vulnerable in our communities? I think a lot of us work on these issues, whether it's people who use drugs, people who are experiencing homelessness, people who are in sex work or of undocumented immigration status. What are we doing to protect the most vulnerable? And how do we do this beyond the notion of charity, the idea that volunteerism and mutual aid are the ways to sort of push us through the epidemic onto the other side? And how do we do this in the context of our neoliberal, austerity ravaged era? So I'm a public health person, and what you learn in public health school very early on is about the social determinants of health. And they've gotten a little purged of any sort of political valence over past 200 years. But if you go back and read Friedrich Engels on the conditions of the English working class, about the Industrial Revolution and its health effects, or Virchow on the typhus epidemic in Silesia, it's pretty clear that they're talking about political determinants of health that have driven ill health 200 years ago, which we can sort of think about today, pulled from the sort of washed out context of the idea of social determinants of health that they teach you in public health school. So Amy and I talk about how COVID is feeding on the structures of inequality in the United States and how we need new politics of care. But I think, you know, and if anybody's read my writing over the past few months, I'm pretty harsh on our current president and the administration, but I think we need to look much further back in our history for the roots of the crisis. And many of you have seen the New York Times 1619 issue from last year. But I keep going back to Janine Interlandi's essay about why doesn't the United States have universal health care as a touchstone for this moment, because it was wildly prescient about why we are now here in the United States in 2020. And in Janine's essay, she talks about federal policy on health reflecting white ambivalence at every turn. And she talks about some of the theories in the 19th century of the theories of Black extinction, where white legislators argued that free assistance of any kind would breed dependence. And when it came to Black infirmity, hard labor was a better solve than white medicine. Quote unquote, no charitable Black scheme can wash out the color of the Negro, change his inferior nature, or save him from his inevitable fate. These were remarks that Janine pulls from the record and puts in her piece in the 1619 essay that she does on universal health care. But you don't have to go to the 19th century to hear this language, right? When I grew up and graduated from high school, Ronald Reagan was talking about welfare queens. But you look to 2020 and Alex Azar is talking that it's the poor health of communities of color that are to blame for deaths from COVID, not the federal response. So this idea of this theory of Black extinction, which from the 19th century has made its way into the discourse of COVID in 2020. You know, Janine also quotes one of the first African-American physicians, Rebecca Lee Crumpler, back in the 19th century. And she said, they seem to forget that there's a cause for every ailment and that it might be in their power to remove it. There's this notion that, harkening back to Virchow and Engels, that these were political choices that were made to push people into the paths of epidemics, to push people into illness. And Rebecca Lee Crumpler says it may be in our power to remove it. Look, we've had no compulsory health insurance in the United States. We've had exclusion of African Americans from New Deal programs. We've had the Hill-Burton Act, which Janine talks about, in which the location of the expansion of rural hospitals in the United States was passed only with the support of Southern senators, with the caveat that their governors got to pick where hospitals were placed across the American South, and you can guess where they went. She talks more in the essay about how the Prussian or the Red Menace was raised as the specter that followed any sort of discussion of national health care. And so where we end up in 2020 is a fractured patchwork of a healthcare system, leaving millions alone against COVID-19, against SARS-CoV-2. You know, conservatives have worked hard to bring about this, always implying that the safety net they were shedding was for somebody else. And there was always somebody darker at a distance and less deserving. Those are the sort of tropes that are sort of resonate throughout sort of the past 30 to 40 years of my adult life. And if there are people who are less deserving, these are not just people of color and African Americans, it's immigrants, prisoners, people who use drugs. But there's an epidemiological disconnect here, right? People who cannot get early care will get sicker. These delays in care mean more infectious people in our communities, further spreading the virus rather than being in facilities that can care for them. So these logics that have been embedded in our discussions of healthcare for close to 2 centuries have put us on the spot today in terms of our ability to respond to this new pandemic. And to be fair, it's a bipartisan endeavor. Ted Kaufman, who was one of Biden's transition team leaders, has said that we can't expect him to do more in 2021 if he becomes president because we are broke, right? Austerity arguments are being made in the name of austerity, even in the midst of in an epidemic, that the national debt, we owe greater fidelity to the national debt than we do to the lives of ordinary Americans. Also, when we think of the epidemic, I think we have to sort of remove healthcare from the discussions of public health. So while we spend more in the US on healthcare than almost any other country, public health spending is 2 cents on the dollar for every healthcare dollar that we spend. 10% cuts, there have been 10% cuts in state and local budgets for public health over the past 10 years to back into the Obama administration, and 55,000 workers are gone from frontline public health over the past 10 years, leading us to the doorstep of 2020. One of the other things that Amy and I are interested in exploring is the idea of the state as an important actor in our lives, right? It's completely under siege. If the logic of Reaganism was that the market would provide, and the 9 most terrifying words in the English language were, "I'm from the government and I'm here to help," Trump has devastated the agencies that are supposed to protect us from the pandemic and lead the response. As Grover Norquist, for a fiscal conservative in Washington, D.C. once said, "I'm not in favor of abolishing the government. I just want to shrink it down to the size when we can drown it in the bathtub." And the question is, who's laughing now about, that DC Beltway quip, which was meant to poke holes in the idea that the federal government was never there to do anything for any good for any of us. So, we spent the end of 2019 arguing about Medicare for all, and it's been well mapped out, but less obvious and just as crucial is to trying to think about what is our new infrastructure of care going to mean moving into the future. If we think about what a better or more just and fair response to the coronavirus epidemic would look like, I think it points us to a better future across the board for our future in confronting crises like climate change and new pandemics, but the sort of lingering health disparities we've seen over the past decades and centuries in the United States. So if we're going to have any hope of slowing the virus enough to protect our healthcare system and healthcare workers, we need a critical mass of people to be in a position to follow the most important measures we need to protect ourselves against the virus. People need to just stay home when they're sick. And some of those who are sick will need family to care for them, right? But employment in this country systematically marginalizes our ability to care for ourselves and others. This burdens women, especially immigrant women and women of color the most, for they're the ones with the highest burdens of care, whether it's paid or unpaid. The truth is stark. Almost 30% of private sector workers in the United States and 69% in lowest wage jobs have no sick pay, right? The risk of job loss and precarious scheduling add to the difficulties for employees without anything like universal sick pay or income insurance. Self-employed and gig economy workers are entirely cast adrift in a time like this. So we already know that paid sick leave slows the spread of epidemics like influenza. There's other kinds of social support, not only paid leave, but food and rental assistance, which are essential in a pandemic when ordinary forms of income may be unavailable. And the social safety net that Republicans, Democrats love to hate is what undergirds successful healthcare systems. And rebuilding it will be the foundation for a new deal for public health that Amy and I have called for. We need to think about other pieces of our social safety net that broaden out beyond health and public health to think about how we're going to make it through this crisis. Gabriel Zuckman and others have talked about salary subsidization in some of the European countries as a way to move beyond the $1,200 one-time payment only to American families that we saw in the early pandemic relief bills. The CDC has put a moratorium on evictions, which many of us think is beyond the CDC's authority as a body, but let's talk about how we can prevent evictions, foreclosures, and forgive student debt. The largest concentrations of clusters of COVID-19 are in places like prisons and jails, meatpacking plants, and other congregate facilities. How are we going to deal with the issue of prisoners and others in these congregate facilities when we have no commitment to sort of reforming criminal justice? So, you know, for any of you who have kids on this call, the crisis of childcare and education has just exploded in American communities. In New Haven, where I am, we have not opened up schools even for a hybrid model as of yet. And upwards of 30 to 40% of kids in New Haven are not even logging on to the system for online education. And so we're setting up a human development crisis and a child development crisis that needs to be addressed, because the pandemic is not going to go away in the spring or the fall. This is likely to be a slow burning event that goes on for the next couple of years. So what Amy and I talked about, and I'll show you what it looks like on the map in our collaboration with Columbia in a second, is that we've talked about building a community healthcare as a place to start to build a new movement that heals us in our body politic, and that will allow us, all of us, to survive in a pandemic, but also to thrive in the aftermath. And you know, Amy and I talked about how we need to build a better future and not just climb out of the rubble of the pandemic, brush ourselves off, and start in the same place that we found ourselves in January 2020. You know, the United States is sicker now with COVID-19 than our industrialized country peers, but we've been sick for a long while in many other ways. Getting back to normal was never going to be a solace for many in our country, and business as usual was what made us vulnerable to disasters like the one we're currently experiencing in the first place. So will it be easy to get our creaking, divided democracy to funnel resources into these programs? Probably not. But COVID-19 is conspiring to show us all at once in a way that no one could ignore how central care is to a healthy society, right? Care is we are in a crisis of care, as Nancy Fraser and others have written about, and COVID has just laid this bare for us all to see. So we have two paths. You know, there's a piece by a cultural critic in the UK named Gavin Jacobson, who writes for the New Statesman, who did a review of a movie which maybe only sci-fi geeks have seen, but it was called Children of Men. And he wrote about it in the context of COVID-19, and he wrote this passage that sort of leaps out at you. And he says, the idea that we're out of time is what makes Children of Men both a mirror and an augur of the world and the world to come. At the end of history, cut off from its past and pessimistic about the future and facing slow death under rising tides, humanity has resigned itself to a somnambulant life. It is a life of finitude, routine, and conformity, one without vision, spontaneity, or surprise, where we no longer seek to live large lives or even strive for a continued existence. Have we become Nietzsche's last men? And he writes this not because he wants to write a movie review in 2020 in the summer, as the COVID-19 epidemic burns across the UK and across the United States. But the question is, have we given up? Should we be the last ones out the door to turn out the lights? So if we started this discussion about race in the United States as a fundamental way of our understanding about what brought us to this precipice, then figuring a way out of this means confronting white supremacy in the US. So Julia Marcus, who's a friend of mine from Harvard Medical School, and I wrote about public health experts in the Black Lives Matter protests earlier this summer in the Atlantic. The reason we wrote this piece, which was called Public Health Experts Are Not Hypocrites, Health is About More Than Simply Remaining Free of the Coronavirus Infection, the longest title ever, is because some conservative commentators and even one Yale colleague of mine, Nick Christakis, were railing about public health people supporting the Black Lives Matter protests. The logic was that all events matter. If Black Lives Matter protests were okay, then weddings, Trump rallies, and the rest were too, in fact, mattered too. In fact, our support of the Black Lives Matter rallies was special treatment, and several thousand public health experts and scholars signed on to this letter in support of the Black Lives Matter protests. But I think, in addition to the work that Amy and I did in the spring, Julie and I were trying to sort of think about what is this all about, the sort of collision of the COVID-19 epidemic with the Black Lives Matter protests. the points Julie and I made were this. One is that public health prohibitionism is a failed strategy. Just to say no to protests or significant events in one's life is just simply not a long-term sustainable thing. We have to think about how we do things more safely in our lives. We've called this approach harm reduction in homage to the people who use drugs, who pioneered these ideas of safer drug use for their own communities. We also made the case to our critics that it wasn't in our power to stop the protests, nor would civic authorities be able to do so either. So it wasn't our responsibility to so it was our responsibility to offer advice and how people could stay safe in protests, and people did. But the idea that all events matter elides the difference between the stakes of what's happening in the US, right? Police violence is a public health issue. Even beyond deaths and injuries inflicted in the context of law enforcement, former Surgeon General David Satcher suggests that 80,000 excess deaths from racism occur in the United States each year. So in the language of public health, communities are facing competing health risks, COVID and racism-related deaths, and trying to decide what matters most is not our job. It's our job to deal with two things at once, but our critics, many of whom have no problem with the national COVID response otherwise, say COVID trumps all and we're wrong to drag politics into the pandemic response in the context of the Black Lives Matter protests. The gravest mistake made by public health experts was allowing themselves to be sidetracked by politics, highlighting the health implications of police violence and systemic racism rather than focusing on the real work of combating the coronavirus, meant that political ideology, that anti-racism became part of the public health equation, right? That was the gravest sin that was made by public health experts this summer in solidarity with Black Lives Matter protesters. But colorblindness, or the insistence that race isn't relevant, reinforces many color-coded inequities. Eduardo Benito Silva suggests this in his book, Racism Without Racists, which talks about the sort of the burden of colorblindness. The same insistence that protests are purely ideological in politics and therefore irrelevant to public health is a way of sweeping racial health disparities under the rug once again. So if you watched or participated in the Black Lives Matter protests this summer, the slogan of defund the police leaves out the second part of that statement, and it's called, the second part says invest in our communities, right? The Black Lives Matter protesters call for a new politics of care. They are an explicit rejection of the theories of Black extinction that Rebecca Lee Crumpler fought against in the 1880s. So I think the idea that our conservative conservatives want so desperately to divorce anti-racism from public health is because it could be the cure to what ails us, right? So I want to go back to where we started before I talk to you about our project with the Center for Spatial Research. But to think about another epidemic that Janine talks about in her essay. She writes that smallpox is not the only health disparity facing the newly emancipated, who are at the close of civil war face a consistently higher mortality rate than that of whites. Despite their urgent pleas for assistance, white leaders are deeply ambivalent about intervening. They worried about Black epidemics spilling into their own communities and wanted the formerly enslaved to be healthy enough to return to the plantation to work. But they also feared that free and healthy African Americans would upend the racial hierarchy. And this was written by Jim Downs in his book, Sick from Freedom. Federal policy reflected white ambivalence at every turn. So we may be dying of COVID-19, but we also may be dying of whiteness, as Jonathan Metzl suggests in his book of the same name, where he shows how the politics of racial resentment have made life sicker, harder, and shorter for many in this country. So say their names, those who have died at the hands of police violence, those who have been left to die from COVID-19. These communities overlap and have been facing plagues ever since our nation's founding. And let's remember, as Rebecca Lee Crumpler has said, that we seem to forget that there's a cause for every ailment, she wrote, and that maybe in our power to remove it. And so that's sort of my reflections, coming into the fall of the work that Amy and I did in March and April of this year, thinking about the new politics of care and what the sort of social and economic and sort of political issues are that faced us. I just wanted to give you a little quick glimpse. Let's see if I can do this without, can I share my screen? Is it possible? Can you see this? So Laura Kurgan from the Center for Spatial Research, her team, Jia Zhang and Dare Brawley, along with my postdoc Suzanne Loyu and research assistant Tommy Thornhill, started to think about how do we think about the new politics of care in actual tangible terms. And we have made this proposal for 1 million community health workers to address the crisis of COVID-19 in our communities, but this larger set of vulnerabilities in health. And I'm just going to walk you through the website very quickly, and then we can open up things for questions. But you're the first people who've seen this, so hopefully it's not going to crash on me. So in this mapping exercise, we've mapped vulnerability in the United States, and we can think about vulnerabilities in many ways. We talk about it in context of the Social Vulnerability Index that the CDC has had for a long time to discuss vulnerabilities in communities to natural disasters, other disease threats, and we've mapped the Social Vulnerability Index on a county level in the United States. But there's other ways to think about communities' resource needs, and we wanted to examine vulnerability from many angles and perspectives. And I'm going to do the Arizona case study so you can see what we mean. So social vulnerability in the context of the CDC definition talks about the counties with the highest numbers of wholly vulnerable populations across 4 areas of socioeconomic status, household composition and disability, minority status, and language and housing type. In Arizona, we've ranked the counties here according to its SBI relative to the other counties in the state. And you can see that Yuma County in the Southwest has the highest social vulnerability index, followed by Apache County and the Native American lands in the northeast of the state. But there are multiple ways of thinking about social vulnerability. If you're a public health researcher, sometimes we think about the context of years of potential life lost or premature death. And this is where you have people dying under the age of 65. And again, we've ranked counties across the US. This is just the Arizona model, where you see some overlap. Apache County has the highest burden of years of potential life lost in Arizona. But back in the Southwest, Yuma County has some of the lowest years of potential life lost as a metric in the state. If you talk about Medicaid expenditure, for instance, the highest number of Medicaid enrollees in the state per 100,000 is again in the northeast of the state, Navajo County, next door to Apache County, but Greenlee County has the lowest, right below Navajo County in the state. The idea is that the way you define vulnerability shifts in space and time depending on how you want to define it. For unemployment, we can see that again, Apache County is second highest in unemployment, but the lowest is in Greenlee County, and the highest again is in Yuma County. We have two counties that are at severe risk for sort of vulnerability if we think about it in pre-COVID terms. But if we start to think about COVID, we see a shift of this. If we're talking about responding to the epidemic or responding to longstanding inequities and vulnerabilities in health, your thinking changes if you're looking at through the lens of the pandemic alone, because Maricopa County in Arizona has the highest rates of COVID over the past 14 days when we ran the model last time, and Greenlee had the lowest. But you don't see Apache or Navajo County or Yuma County represented in this map. Again, this is normalizing COVID cases by population, but it also it drives you away from the places that have had longstanding vulnerabilities across the state. But when you go to cumulative COVID deaths, Apache County is resurrected in terms of the vulnerability, so in terms of the sheer number of people who died among Native American populations in the state. And so, we would love as public health researchers to tell you there was one way to think about vulnerability in the context of this pandemic, but I think as we started to look at the data, we realized it was not the case. So with these 4 metrics, different counties in the state and different counties across the United States have different kinds of terrains of vulnerability shifting depending on the 7 metrics we use in our map to define it. Some of the levels of vulnerability described in each metric are similar, but for others they can be very different. In the southwest corner of the state, Yuma County ranks highest in the state of times of SPI, just above Apache County, but is relatively low in rates of years of preventable life lost, and has the second lowest unemployment rate in the state. In September, the county ranked 5th in terms of total recent COVID cases, but 3rd in terms of total deaths from COVID. So Maricopa, where Phoenix is, had the highest number of recent COVID cases in September, but it has the lowest number of Medicaid enrollees in the state and relatively low rates of unemployment and years of preventable life lost. So vulnerability, looking at through the lens of the pandemic and looking through the lens of traditional measures of vulnerability, social and economic and health vulnerability, doesn't necessarily send you to the same answers. So we wanted to think about, if we had 1 million healthcare workers to sort of tend to the new politics of care and build a foundation for behavioral public health, where would we put them? And we don't have there's no data that would help us to say, for instance, where would you put them to minimize deaths or maximize Medicaid savings, for instance? We simply don't have the data, and it's not available to do this on a county level. So what we did is we used our map to divide our community health workers across the United States based on Medicaid enrollees, and you can see California in deep purple, and Texas and Florida and New York have an enormous amount of the community health workers of the 1 million we'd like to allocate under bills that have been proposed by senators like Michael Bennet, Elizabeth Warren, and others, Kristen Gillibrand as well. But within states, that's up to you, right? And we're asking people to use the map as a way to sort of look at a lens about what your trade-offs are in health and spending for community health workers in the response to the pandemic. Remember, with the social vulnerability index, here you could allocate workers to each county based on the social vulnerability index, or any of these other 7 metrics on the left-hand side. Here, if you use the social vulnerability index, you'd send most of your community health workers to Yuma County, and you'd send the least of them to Yavapai County in Arizona. But any pairs of choices sends different kinds of resources to different counties. If you look at SBI versus years of productive life lost, if you're stressing SBI, you're going to send more people to Yuma County. If you're going to send more people to Gila County if you're interested in years of preventable life lost. This is the same thing with SBI and COVID cases. If you're thinking just about COVID, everybody's going to Phoenix. But if you're talking about social vulnerability, you're talking about Apache County and Navajo County and a lot of the counties in the deep orange here. The same thing about thinking about history and about current events in COVID. If you look at historic burden of COVID, it's Apache County and Navajo County that where you'd send the most resources. But if you want to talk about what's happened today over the past 2 weeks in Arizona, you'd send them to Maricopa and to Phoenix. And so we're going to launch this next week, but you can basically go to any state and play this out as well. Here's the map of New York to help people think about what mapping the new politics of care may look like in the United States, whether you look at Medicaid enrollees. So the yellow means more Medicaid enrollees per 100,000 people, unemployment, COVID cases, years of potential life lost. The terrain shifts before your eyes in terms of how vulnerability is expressed across the American landscape. And all this data is going to be updated regularly so that we can watch this play out over time. Amy and I and others are working together, as I said, to write a book on the new politics of care. We're trying to work with both congressional offices, but also a coalition of large civil society actors, including the SEIU, NARAL, and a whole bunch of other NGOs that are spacing out right now on these issues, color of change. And the idea is that should we have a new administration in January, that the task before us is not simply getting to zero in terms of COVID cases, but providing a foundation for better health and for more resilient communities in the months and years ahead. So I'll end there and we can discuss what you think, or if this is terrible and it's a bad idea.
I mean,
well, I'll begin.
I was excited to like see your, I don't know if I'm echoing at all. I was excited to see the website and was glad you were able to, I guess, like present it to us, just because of the work I'm interested in terms of access to care. And so I can't speak for everyone, but thank you so much for your presentation today.
Yeah, and we're interested in, you know, Laura and her team at Columbia are interested in doing case studies on different places. You know, in particular, New York City won't give us the data on census tracts in the city for COVID, which is super annoying because we'd love to do a case study of New York City, but we've been talking to people in Albany about these millionaire taxes and whether we can fund a new politics of care in New York with some of these schemes that were predating the COVID pandemic, and whether COVID gives us a wedge to sort of expand access to care across New York State. They asked me what my interest was in this, and I said I'm a New Yorker in exile, and so I care about what happens to my city.
Mm-hmm.
Greg, can you say something about the difficulty in getting that data, or what that conversation has been like in terms of approaching the city and having the city say that they won't share it?
I don't think it's anything sort of nefarious. I think they're simply overwhelmed, and instead of having us ask for these bespoke, expansive data requests at the census tract level that can use public data sets, and we should go back there and look at it first. Even if it's broken up by zip code, it may be helpful to us. What was more distressing to us is that, you know, from a modeler's perspective, we wanted to do this as an optimization exercise and say, like, if you send community health workers here, you can save more lives or you can save more Medicaid dollars. And then we realized, like, the Bureau of Labor Statistics doesn't have county level employment figures for how many community health workers are working currently at the ground level. You can get it for metropolitan statistical areas, but you can't get it for every county in the US. I'm like, why not? You know, so we ran into obstacles as we wanted to try to sort of make this a more objective exercise. And then we realized, in talking to some people who actually do work on community health workers in the US, said, you know, maybe you're looking for an idea of misplaced precision, and going where the need is actually equally important. So we tried to pull the map is based on what data we had rather than the data we wanted to have.
I had a question also about, you said you had a hard time getting the data on like where community health workers even were in the first place. I wonder how much of that might be because of the different kind of organizations that sponsor community health workers, like at different levels. Like some of them are federally funded, but a lot of them are also funded by like independent sources or something else as well. I wonder how much of that has to like plays into the lack of data around this.
Well, an interesting thing is that there's an economist who worked for the Milken Institute, which, you know, was surprising to me, but he had done a state level analysis using the Bureau of Labor Statistics state level coding for community health workers plus mortality, and tried to sort of figure out how much mortality was attributable to one, you know, an increase in one community health worker buys you this much in Medicaid savings or life savings. And we talked to him and he said, look, we could do this for the county level, but the data is not there. So it's just a problem. And I asked labor economist friends, you know, is this true? And they said, yeah, you're not going to be able to get this data beyond sort of the MSA is the sort of most sort of granular data you get in this country in terms of labor statistics, in terms of ongoing sort of employment figures.
Mm-hmm. I see Peter put up his hand.
Yeah, I just want to make a quick comment saying that I appreciate the visualization. It reminded me a lot of the opportunity at which Adam.
Keep talking. You're very soft. Can you hear him?
Can anybody hear me?
That's better.
Okay. Yeah, I just got to hold the mic a little bit. I just wanted to say I appreciate the visualization. I thought it made the information a lot more easy to understand. It reminded me a little bit of the opportunity atlas that Raj Shetty makes.
Yeah, I'm super excited about getting to work with Laura and her team at Columbia. They do all these enormously wonderful visualizations, taking public data and putting it into forms that are, frankly, much more understandable than in any scientific paper. I'm sure you saw the $1 Million Box project that they did with others. And so we're hoping we can continue to work with Laura, because I think this is a very sort of powerful tool about translating information about statistics and numbers into sort of visual form that gives people a real chance to sort of experience the data in a much more sort of visceral form.
And just, can I make a quick continuing comment? I work in a school right now, and it was interesting showing kids that visualization, because they were immediately able to generate their own insights. So I'm curious, you would be okay with me sharing this with some of the teachers here to see if they're able to kind of understand what's going on in a larger context.
Totally. We're gonna launch it next Tuesday. I'll send the link to Raquel, and she can send it out to the whole group. We're all, if anybody wants a guided tour through the website, I mean, we did that visual map in the front because just throwing people into the map was sort of jarring for people in our first sort of exposure to our friends. But yeah, the whole idea is that it should be used by everybody to sort of explore what vulnerability means in their communities. I'm sure there's other, there's a COVID vulnerability index map too that some people have put together. This is our version of it. There's lots of versions of it that we could talk about. But what was shocking to us was the fact that you could be in one county that was vulnerable in one way and not so vulnerable in another. And that COVID, we hear that COVID tracks with certain kinds of vulnerability, but it does and it doesn't, depending on where you are in the country.
Hi, Greg. Thanks so much for your incredible presentation and work. I'm completely obsessed with your thinking about vulnerability. But from my perspective, I'm an anthropologist and a nurse researcher. I've thought a lot about the role of one's perception of one's vulnerability and how that influences one's behaviors and one's actual vulnerability. And I was wondering if you could talk a little bit about that sort of emic perspective of vulnerability.
So can you explain more? Because and how, I'm an epidemiologist, so I ask, can we measure that? But because we should be able to, I mean, we can,
So an example that I'm thinking of for COVID, and certainly this is true with all of the work that many of us have done around HIV all these years, is thinking about how vulnerable one feels. So with COVID, if I feel vulnerable, I'm more likely to wear a mask to socially distance. Whereas if I have the perception that I'm not vulnerable, either for real scientific reasons, I'm young, I'm healthy, I don't come into contact with people, or for sort of false reassurance related to some of the political reasons that we're all aware of, how that influences my actual vulnerability and potential health outcomes, both individually, but also community-wide.
well, so there's ones about this thing. So I have trouble talking in this register because I'm not trained properly to sort of discuss it, but I do think the question about self-efficacy and whether people feel vulnerable, there's a starting point, and then there's the ways we frame that vulnerability for them through the media, through public policy. And I think my friend Josh Baruchas from Boston Medical Center and I've been talking about what that means in the context of behavior change for COVID-19, so mask wearing, social distancing. And it's not just about vulnerability, it's about how people experience loss. What is tangled up in the sort of gender norms about mask wearing in the United States, which I didn't know they had gender norms until a few months ago, it got entirely gendered for certain kinds of people. And how do you sort of reshape perceptions about vulnerability that are overlapping, not just about COVID, but about what it means to be a man in the United States, et cetera, which I don't see how we get to any sort of long-term sustainable behavior change unless we sort of delve into these issues, which I don't think you can map. I think this is frankly the training of anthropologists and sociologists to help us understand what does this look like, and then some sort of the interventional piece of it, like how do you intervene at the individual level, but probably at the community level, to sort of reshape these notions of vulnerability in a way that helps people live healthier lives and practice these sort of really basic public health techniques that are going to keep all of us safe.
Agree. Thank you. And, you know, if you weren't exiled, you'd be walking down the street here in New York and you would see this incredible gender differentiation between mask use. It's really so striking. It's pretty hard to believe.
Yeah, I'm in New Haven, same thing.
Sandra, you put your hand up.
Yes. Hi. It's very nice to meet you, and it has been great to hear you speaking and hear your expertise. I think your app and your website, it's a great idea. I think in many ways it's more informative than the application that Johns Hopkins has, since it incorporates, the social determinants of health. And I have 3 questions for you that I prepared. I'm just gonna ask one for now. So it is clear to me that universal coverage will help diminish the gap in health outcomes between the rich and the poor. This has been suggested consistently in studies where universal coverage was estimated to prevent chronic disease morbidity and mortality, and ultimately increase life expectancy in populations that would have not have obtained healthcare otherwise. Yet, how can it be explained that even in societies where a universal healthcare system is in place, I'm thinking about some European countries like the one I'm from, Spain, or other countries like Belgium, mortality rates per capita for COVID are higher than that of the US, where a neoliberalist profit-driven system is ingrained in the society. So wouldn't the consequences of this epidemic or pandemic depend on a realm of multiple factors such as contact tracing, containment strategies, mask mandates, travel bans, lockdowns, availability of resources, most importantly, testing capacity, cultural behavioral factors of the population like tendencies to isolation, use of public transport, type of jobs in the community, whether these require social interactions or not, or even the basic reproductive number of the viral strain, in addition to having or not a more or less a fair economy market type. So I wanted to hear your stand on that.
So yes, and yes. But look, I mean, and it's hard to run a natural experiment to sort of figure out what of this is true and what is not true. But if you look at places that have been able to sort of handle, all things being equal, if you look at Germany and New Zealand and South Korea, you see places that have done all the other things that you suggested need to happen, but they also have the fallback of health systems that can take care of their populations.
Mm-hmm.
So there've been all these discussions of herd immunity that have been rolling through the press over the past couple of weeks, and the specter of Sweden being able to sort of let people go back out into the streets and rely on some notion of herd immunity to protect them. But Sweden also has a robust safety net and healthcare system that allows them to sort of address people who fall between the cracks. We just have it's not inconceivable that a country that's sort of worse health outcomes than its industrialized peers is going to do more poorly in the context of the COVID-19 epidemic. That's a hypothesis. It's not about per capita health spending, it's also about the social safety net. Betsy Bradley, who is a colleague here at Yale, who's now at Vassar, wrote a book called The American Healthcare Paradox, which said it's not our healthcare spending that matters, it's our social service spending that matters. And that the social safety net has made us sort of acutely vulnerable in the United States to inferior life expectancy compared to our industrialized nation peers, et cetera. And so, yeah, so you can see it now in Europe. Europe is again having it's having a new wave of infections, and Julia Belluz from Vox, who's a science journalist colleague, has talked about how the difference between the European nations has been the way they use the summer in preparation for the fall. And she's not casting blame, but she's suggesting that countries like Germany scaled up testing, contact tracing, a whole set of other interventions where many of their European neighbors sort of just thought of the summer as more of an excuse to relax restrictions than to sort of store up resources for the fall when the second wave was liable to come. And again, this is going to be fodder for dissertations for the next century about like who did what badly and who did what badly when and how. But do you think sort of we started with a poor baseline in public health and in social services and healthcare in the U.S., which did nobody any good before COVID. As David Satcher said, 80,000 people in the U.S. died in the U.S. Due to sort of the implications of systemic racism. Our life expectancies, if Peter was talking about the opportunities map, but when you look at some of the maps of this health disparities in New York City alone, these were all there long to see before COVID hit us. And so, yeah, so it's all multifactorial in testing and, are not all of it's part of it, but starting with a better baseline probably would have been given us a better today.
Yes, I agree. Thank you so much for your insights. I agree with everything. May I ask another question, please? Keeping in mind that socioeconomic status, SES, would be associated to access to healthcare in the US, I would think that vulnerable populations such as minorities with lack of access to healthcare would be more prone to die from COVID after contracting the disease, which is something that has been observed in the city of New York, where multi-ethnic neighborhoods like Queens and parts of the Bronx and Brooklyn have been affected more severely by the pandemic. However, there are studies published recently that have been shown that even after adjusting for socioeconomic status, these minority populations were at higher risk for disease. In your opinion, how would you interpret this, or what does this suggest? Does it suggest systemic racism?
So about 200 kids have died of COVID in the United States.
Mm-hmm.
And children are far less likely to have severe disease. Most of these children were Black and Latino,
Mm-hmm.
but many of them had underlying conditions like obesity, diabetes, asthma. And so we can control for SES, but we need to control for underlying conditions, which
Yes.
Are downstream from SES, or
Mm-hmm.
downstream from disinvestments in social services like affordable, safe housing, preventive health screenings, et cetera. So SES alone is maybe too far upstream to think about it having effect, and talking about sort of burden of disease across communities is maybe another way to think about it. And that's pretty much panned out.
Yeah. Thank you. I agree.
Jacob, do you want to ask your question?
Hi there. Thanks, Greg. That was great, and I'm really excited to hear that you and Amy are working on turning your Boston Review articles into a book. I actually taught one of the articles as one of the first things we read in my critical disaster studies course this semester. So it'll be nice to give them a book version instead of the article version. I wanted to so I come at vulnerability from a disaster perspective and from the kind of the tradition that largely comes from geographers and thinking about vulnerability to hazard being what produces a disaster, and that vulnerability to hazards is largely about limited choices, right? So both being in dangerous places, right? So being the limited choice of you live on a hill that's susceptible to landslides, and also limited choices about how one after exposure to the hazard. And that seems like a potentially a different model for vulnerability than what comes out of epidemiology, largely because there's not, because there is the biological question. There's differing biological vulnerability to COVID, right? That is somewhat structured by social determinants, but not entirely. And so I'm trying to work my way to the question. What we would say in disaster work is that what we need to do to decrease disaster risk and decrease vulnerability is to give people more choices not to be in unsafe places, which generally means giving them more political power, right? And giving them and building more equitable societies that enable people to have the choices to escape dangerous places. And so the question is, how does a community health worker model, or how does a community health corps model, if it's keyed at kind of decreasing health vulnerability, how do we then have those people also build power to give people more choices and be in less dangerous situations?
So, no, so Amy and I have talked about this explicitly, is that this is not about, so it's interesting, in some discussions of this, people have glommed onto it because it's expanding sort of a healthcare worker cadre out in the field. We see it as extending a community organizer cadre out in the field. And, when we were talking to Gillibrand and Bennett's office about their health force bill, they're like, this money's going to flow to the CDC, to local and state health departments, and that's how this is going to work. We're like, well, maybe you should send it to Make the Road New York and to different kinds of community groups who have been in these communities, working with them forever, and you don't need sort of like technical healthcare skills. If you need somebody to get screened for diabetes or to link somebody up with a housing advocate, that can be the role of this person, but you need to build power in communities. So I don't think epidemiology and disaster studies are that far apart. I mean, I teach a course here that I came up with 2 years ago called Political Epidemiology. It's about how policy decisions mediate social and economic determinants that create ill health. And so you have to go, if you go upstream, it's all going to be about policies and choices and resource allocation and opportunities and limitations of opportunities. And so I there's not a lot of daylight between us in terms of how to think about it. I think one of the things about, as Amy, you're writing this, is that I've actually, you've sent me several book recommendations about labor organizing in health, and others is that I think there's actually stuff from outside of public health that needs to be integrated into our thinking about this. And I was a little bit weirded out about doing this presentation based on the Boston Review articles, because it's not scientific. It's like speaking in this register, which is sort of public policy, law, advocacy. But I think that's the point. The point is that you're going to have to rely on sort of a multidisciplinary approach to get at what ails us right now. And I think that includes anthropology and sociology, that includes history, disaster studies, and the like. So I just think it may be great for academic purposes to sort of stay within your lane. But I think unless we sort of combine our forces, you don't get through a world historical crisis by sort of chipping away at your little problem for the rest of your life. And so I think pulling together all the knowledge we have represented on this call and other places is the way to move ahead. And so I think like learning from disaster studies is going to be important in thinking about how to deal with this disaster.
Well, as you know, that's the answer I wanted you to give. So thank you.
I was ready.
I just wanted to make a comment as well. I am from a psychology background. I'm getting my PhD in counseling psychology, but a lot of the work I'm looking at, again, for access to care is leveraging community resources, right? So we work in my lab, we work with like family peer advocates to deliver evidence-based care to families in underserved communities. And what you were saying about like not you said stay in your lane, but the message I was getting was like, don't stay in your lane, like to reach out to interdisciplinary perspectives to kind of help inform these decisions. And so I just wanted to kind of like glomp onto that as well, and like in terms of like empowering communities to do the work themselves within their communities, because often they know more about it. I think about like community participatory action research to help these communities inform decisions about how to make something like the community health works. It's community health works, right?
Community health workers, yeah. I mean, just, yeah.
Yeah, like making something like that actually happen. So,
I mean, that's why, like, we were like, when we talk about the community health worker core, whatever we want to call it, the health workforce, is that it is a community health work model, which means you have to live within the community to do the job. So it's not somebody who's driving in from Nassau County to do work, you know, in Queens or in Brooklyn. It's somebody who lives in the neighborhood, who knows the neighborhood, who's part of the neighborhood, and you build up from the ground up, not as sort of in a position of expertise or resources from the outside that has no connection. And that's the power building community organizing model that sort of frames the work we do.
Jean-Paulo, I see you put your hand up.
Oh, is it my turn already? Did Audrey? Okay, cool. So Greg, thank you. I really appreciated the talk, and I am part of some parallel discussions about policies, transformative policies in the housing space, and you know what will things look like. And I really love the Boston Review pieces, and I love that that's what you talked about. And so I wanted to ask you a question that connects some of that, and asking you maybe to reflect on your activism in your ACT UP days, because sometimes this is, you're not guilty of this, but sometimes in these kinds of discussions, people will say, you know, communities should be self-determining, and it should be partners, and it should be a democratic stuff at the bottom level somehow when we're talking about local solutions. But then we need really big, transformative, federal, international types of solutions fundamentally impacting our political economy. And sometimes in the discussions, that bottom-up stuff sort of fades away when we're talking about the really interesting, good ideas. So when I was very interested in the New Deal types of ideas you have for public health, and I was wondering how do you see social movements impacting at that level? And what made me want to ask this question is that Make the Roads theory of change, for example, is one where they want people to do really progressive, big, bold policies, but that social movements will need to be mobilized to make sure those policies are actually progressive and they don't run into all the entrenched inequalities. Given that ACT UP has such an interesting relationship in history of that kind of stuff, I wonder where you come down on that.
So it's complicated for me because I have very complicated relationships to that past. So, you know, in the 1980s, nobody gave a shit of whether we lived or died. And so we had to make our own, you know, we had to form Gay Men's Health Crisis in New York City, or, you know, God's Love We Deliver. I mean, we built a whole social healthcare legal advocacy infrastructure to take care of ourselves from the ground up, from a well-resourced, often community of white gay men. But that being said, we did that. Many of us I worked on federal policy for a long time, and was very interested in sort of like making big picture changes that were going to be long lasting, and sort of address the problems that we faced in the 1980s. But I think what we didn't learn, you know, we formed the Treatment Action Group in 1992, 1993, and left ACT UP because we thought these big picture policy changes were, you know, the way to go, and we were wrong. Because what happens if you don't have a social mobilization underneath it, nobody gives a damn. And this is why the community health, you know, we can have all these sort of fancy Boston Review articles that talk about like neoliberalism and all this stuff it's all well and good, but unless you build power at the community level, it just, there's a book by Ismoglu and Robinson called Why Nations Fail, right? And it doesn't matter what you think about the book, but there's this one little line in it that flips me out every time I read it. It says, people in power make decisions not by accident or by ignorance. They do it on purpose, right? There are incentives built into the system. There are structures built into the system that are absolutely purposeful. And if you're going to deal with that, it becomes a crisis of governance. So we're not just in a health crisis or a social service crisis, or we're in a political and a governance crisis. And that isn't about sort of a technocratic solution that egg-headed academics can sort of come up with, put into policy papers and send to their members of Congress. It has to do with about generating real power to make a difference. And this is why I talked about the Black Lives Matter protests. I mean, how many years have we talked about the problems in policing? And in the summer, reforms change on the local and state level, which were not on the table 18 months ago. And so how do you sustain social movements is another. I don't do work on social movements in an academic sense, but I want to know, how do you sustain and build social movements? Because the right has done it really well, right? After Goldwater's defeat, they made a pact that they were going to sort of take over school boards, city councils, mayoralties, state houses, presidencies, et cetera. So we've never had a sort of social theory of change on the left that's been any damn good. We sort of gave it up in the 60s. And now we're seeing, whether it's, AOC and the Green New Deal or the Black Lives Matter movement, we're seeing a whole bunch of young people sort of rediscovering a sort of politics of social mobilization that sort of the Democrats and the sort of liberal American elite have sort of discarded as sort of with a much more sort of interest in making change from the top,
Oh, I really appreciate that, Greg. And I have to say, in the housing kind of universe discussions, you have well-meaning liberal eggheads who have a sense like, I have a great idea. Why won't it? And they need to realize that great ideas don't carry the day, right?
You need both, but I don't know. I mean, these are sociologists of social movements talk about primary and secondary actors. And the primary actors are the people who are closest to the problem. And the secondary actors are the lawyers, the activists, the academics who are there to help. And when I look back in like ACT UP's history or my work in South Africa, yeah, there are lots of lawyers and sort of professionals about, but a lot of the grassroots stuff was happening by people who were dying of HIV. It's just the history of social movements. They don't happen by these sort of well-meaning elites. It's people going to get out on the street if they feel like they have a stake in what's happening. And whether you read Francis Fox Piven or anybody else, it talks about these sort of grassroots movements driving social change rather than it coming from the top down.
Thank you.
Shannon, you want to go ahead?
Yeah, thank you. Thank you, Greg. This is fascinating. So thank you for taking the time to talk to us about this. I have a question stemming from the series of articles that you shared with us. And I'm wondering about, you critique in the articles technological solutionism, and I completely agree with that for many reasons. I mean, one, thinking about if we're using smartphones to collect data, we might not be collecting data on the most vulnerable people who don't have smartphones, or, all of this data, it's going somewhere. It's going to big tech, which is giving them more power, more money, all of this. So I can think of a million reasons to critique looking to technology as a solution, but it does seem like it gives us a lot of power. And I wonder if you can share any thoughts you might have about how we build using technology into this more community-based model. How do we do that in a way that doesn't just, give more money and more power to big tech, but that does harness the power of technology to help us reach solutions?
So just a story. In 2000, I was talking to a bunch of colleagues who work in Malawi and other places around sub-Saharan Africa, saying that access to viral load and CD4 tests was a big problem in terms of getting people access to antiviral therapy. And they were being told by WHO that, you know, there are these big solutions coming down in these big lab in a box proposals to sort of make technologies that are appropriate for settings like, you know, rural Malawi. But nobody's ever gone down to actually ask people and doctors and nurses and patients in the field what they wanted. And so we did a project in the early 2000s where we said, you know what, maybe the first step of this is to actually go into the field and talk to people about what they need. So what are the specs you need in a assay for viral load or CD4 in the context of HIV that are going to work in a rural Malawi setting or in Botswana or wherever we're talking about where we're doing these surveys. And it turned out to be a dipstick, right? Something that was much more like a dipstick or something that was not relying on any sort of lab in a box or fancy machine. Making a simple technology like that is incredibly difficult, right? It wasn't a dipstick may look simple, but to do a CD4 assay in a dipstick format was nigh impossible. And so you needed to get people together with lots of different technical expertise to build something to specification. And that's, I think, the question. It's like, so I sat on all these crazy conference calls in the spring, helping out a group called Schmidt Futures, run by the old Google Eric Schmidt's foundation. And all these Silicon Valley people were like, we have an app for contact tracing. And like week after week, it's like, and did you talk to a public health department? It's like, no, but we can do this. Like they were so pleased about what their technology could do. But in most cases, there was total disconnect from what the needs were on the ground. So I'm not like a Luddite in terms of no technology ever. I'm just not fond of the idea that that it's again going to come from the top down, designed by people who would know sort of real feeling for what's needed in the field or on the ground. So yeah, so I think technology is important, but like, and all these COVID contact tracing apps, where are they now? Not many, you know, there's a total, you know, Schmidt Ventures just pissed away a whole lot of money on a lot of developers who, you know, don't have much to show for their work right now. And so, yeah, so I think technology is good, but again, it has to be ground up rather than top down and built to specification.
Audrey, do you want to ask your question?
Thanks so much. And Greg, I really appreciated your comments a little bit earlier in the conversation about staying in the lane, not staying in the lane, and then the need to think about things across disciplines and to collaborate. And I'm wondering if there are some things that you can see in retrospect, given your career, what kinds of collaborations have been easy, or what you would say to people who are leaving the academy for new jobs in the academy and who are really trying to answer questions across disciplines, because so much of our work is, we're sometimes rewarded for staying in our own lane. And so I'm wondering if you have any kind of suggestion or ideas about how things have gone for that, how that interdisciplinary work has gone for you.
So we're being recorded, just don't send this to my dean, but like, so I'm up for promotion now. I'm like 57 years old. Jacob knows it's my birthday. But I'm 57 years old and I'm being told what I need to do in order to get promoted. And it's clearly that nobody wants to hear about the Boston Review articles or anything that's not classic epidemiology. The incentives in academia, I don't know, maybe it's different at NYU and other places. The incentives are very, very strong to staying in your discipline, chipping away at a small problem that's handed down to you from your mentors. But it's really reduction, and it, particularly in the context of NIH-funded research, it's really what is going to get funded by NIH. And so I think there's lots of huge structural disincentives in academia to doing the work that matters. That being said, I think you find your people. At Yale, it took a long time to find, Amy. I knew Amy and Allie, but there's a whole bunch of people in sociology and anthropology, in the medical school, in the architecture school, and other places that are trying to sort of work towards sort of a common set of goals around social justice and health. And we work together, and we the project with Laura Kurgan at the Architecture School of Columbia, it's like, I don't know that many people who work with people in architecture schools and public health on stuff like this, but like, it made sense. You needed to put this out in a visual format. It doesn't make sense to be the 6,000 word essay in a Boston Review that 200 people read. It needs to be out there in a way that's much more digestible. So I think it's really hard to do it in the context of academic settings, and sometimes centers are helpful. We started the Global Health Justice Partnership because the public health school and the law school could formalize relationships they wanted to have, particularly from the public health school's perspective. But it's really clear that, particularly for NI soft money people, that you're pushed into sort of most conservative notions of what's worth being studied in your field. And you just, I don't know, not getting down on academia, but a little bit, it's a little bit hard to take in the context of COVID. And COVID has been interesting because everybody in my department and a lot of people around the university have sort of just, gone off chasing after the epidemic in ways that, with abandon that they wouldn't have done 12 months ago, because the pull is so extraordinary, the crisis is so extraordinary, that they're forgetting about what the sort of normal structure of incentives will be. Give us a couple of years and people will be slowly drifting back to focusing on what they do. But I think it's really hard to do. Everybody says they like multidisciplinary, interdisciplinary work. I'm not sure that department chairs and promotion committees and provosts are actually that fond of it. Not to be too pessimistic.
If I could just ask a follow-up, I think that, well, first of all, happy birthday. So let's say that. But I think that I was also thinking about this, not so much in terms of finding the colleagues with whom to collaborate, but also, when you got asked the question earlier about the perception of vulnerability, and you were thinking, or at least in part of your response, you kind of indicated, okay, wait, how would you measure that? What would that look like from your point of view? And I think sometimes in interdisciplinary projects, those questions take a lot of time to work through for teams. And so, sort of irrespective of the support that you're getting at the university, have you had experiences where you've encountered maybe epistemological differences or things that were getting in the way of collaborating, and how to get around that?
So, first of all, I do think it takes time. So Meg Satterthwaite, who's at NYU Law School, set up something called the Human Rights Lab a few years ago. And it was a standing body that had Sarah Nuckley from the Law School of Columbia and Meg at NYU Law put it together. But it had architecture people, epidemiologists, social scientists, and you sat with the problem for a while. And grossly underfunded because we needed more time you need more time to be together, right? You need more free time to understand what the problem is from sort of a 360-degree perspective. And we simply don't have enough time to have those conversations. I think people get dogmatic about their sort of disciplinary expertise and can sometimes be defended against it, but people wander into interdisciplinary work, sort of have an idea that what they know is not the be all and end all of problem solving. It's the question about that we were talking about people's feeling of risk and vulnerability. It's pretty clear from a public health perspective that we need to get at that, but I can't think about how to do it as an epidemiologist at all. I do think, my friend Josh and I are writing right now about it. Like, how do you structure incentives that are tied to psychology, sociology, anthropology, that are going to get people to put masks on, that are going to change the gender dynamics around mask wearing. So we're going to have to talk about how to think of it through the lens of gender and sexuality. So there's all these things to do. There's not a lot of spaces to do that in. There's not a lot of time to do that in. I don't have epistemological problems with different disciplines. I just have I just feel walled off from them too much of the time.
Anne, you want to ask your question?
Thanks, Brittany, and thanks, Greg, for this presentation. It's been really interesting. I wanted to ask a question about your idea about this intervention of a community health worker force and your ideas about how to build it up, but in thinking about the implications of racial and gender inequalities. And specifically, like you talk about how do we intervene in communities to address these problems? But I wonder about how do we implement interventions in ways that won't reproduce racial and gender inequalities, in particular, in thinking about, for example, historical accounts of how reproductive labor tends to fall. Reproductive labor in the sense of paid work, for paying for work that tends to be related to the household or for care, has historically fallen onto women of color in particular, and it's a way that white women can benefit from shifting their responsibilities in the household regarding care to more vulnerable women in particular. And I'm wondering if you've thought or have thoughts about how you think we can build up a community health worker force that won't reproduce these similar inequalities for women of color in particular.
So, I mean, we write a little bit about in the piece about politics of reproductive care and the way we think about labor in the country. I think we have to foreground these issues sort of plainly and explicitly, and that care work is gendered to begin with. It's racialized to begin with, as you're describing. And I don't think it's sort of saying it's going to be from the ground up and community-based is enough to sort of address those issues. So I think, this is where we need to sort of be able to sort of foreground issues of race, class, and gender, sexuality too, in a way as we build this up and do it and this is, if you've been part of social movements in the past, these are issues that get played out all the time. But I think sort of trying to maintain a specific focus on it, and it's something Amy and I talked a lot about this in terms of putting together this book, and that we need to, in particular, thinking about the gender lens that is not super apparent in the Boston Review pieces, about how the crisis of care that we were talking about in the piece, comes from Nancy Fraser and her discussions about a feminist ecological approach to care. And I think we just sort of have to sort of go back into those literatures, into those sort of social movements, and think about how to address that. I mean, I was a Open Society fellow about 5 or 6 years ago, and one of the fellows with me was doing a lot of work about how exploitation of au pairs and nannies in the context of race and gender in the United States. Janie came and a bunch of different other people working on this and trying to think about how do you involve people who do organizing among home health workers, among nannies, among people who are doing care work as it's been broadly defined, so that they're part of the sort of social mobilization from the beginning rather than an afterthought. I just think the only way to deal with it is to face it head on. That's like it's simplistic, but it can easily get swept under the table. And I think, this is actually an important intervention, because I think we have to sort of deal with this as we sort of articulate it. The Boston Review pieces were sort of a sketchbook to think about this stuff. But if we're going to think about the real implementation, I think thinking about the racialized and gendered nature of care work and what that means for a new politics of care is important to think about.
I can ask a question. Thank you for this, and happy birthday again. It's nice for you to spend some time with us. So I had a question, just because we're sitting in an urban seminar. I was wondering if the urban-rural divide ever comes up in your work and modeling. The reason I asked this question was because back in March, when New York City was in the epicenter of the epidemic, there were all these calls of the death of the city, that density and the population density and urban density was the cause for the spread. But obviously, since then, since March, we've seen spreads happening in rural areas and suburban areas. So I was wondering how flows and social vulnerabilities change from urban to rural spaces? And is there something distinct from, let's say, concentration of social vulnerabilities happening?
So it's interesting because I have to give another talk next week, and we did this work in Ohio, where, again, I work with administrative data. So I work with shitty data that's hard to get, and it's incomplete. But we sort of used opioid deaths, overdose deaths in Ohio to map need for opioid agonist therapy, for methadone in particular. And what we wanted to do is to sort of plot the distance from concentrations of need to where you could get access to methadone. And what we found is that while the need for methadone is dispersed across the state, the services are all in urban cores. And so so we were doing is there an opioid agonist provider within 15 minutes to 30-minute drive of you? Yeah, if you're in a city in Ohio, great. But basically, you are out of luck, and you're gonna have to drive, 30 minutes or more to get access to methadone in a suburban or an urban, a rural setting. And so the resources for care are, if we look at the state of rural health in the United States, rural hospitals are closing. Even before this, they were closing. Now they're under siege with the pandemic, but rural health was under siege, before the epidemic happened. So there's a whole sort of discussion about divestment in public health has to also be thought about in the context of consolidation of healthcare. A lot of healthcare systems like Yale New Haven Hospital, where I am, are consolidating, buying up all the other hospitals around them, and they're closing the ones that are at the periphery and that are not serving enough patients to be useful. So I think there's a huge urban-rural divide here, and some of it passes through the suburbs, but it's often pretty distinct.
Just to follow up to that, there was this kind of claim made, especially after the 2016 election, that rural voters are, more pro-Republican. So has the coronavirus or other, even the opioid crisis shifted, either political sentiments or sentiments to increase welfare access in rural spaces? Because it seems, as you said it, welfare in cities is logistically a slightly easier task. But it seems like providing welfare in far dispersed rural spaces is an extremely different endeavor. And so even the idea of building community healthcare workers, I can kind of visualize what that would look like in a city, but in a rural space where there's just a dispersion, etc. Are these less conducive to politics of care, etc.?
Well, the community health worker model is actually a lot of it's used in the context of non-urban settings in sub-Saharan Africa and other places. So I don't see that as a problem. The politics of care in terms of the political acceptability of these kinds of things, it's hard to tell if the opioid epidemic has changed thinking or COVID has changed thinking. I'm on the PhD committee for a student in poli-sci who's looking at the opioid epidemic and whether it's changed political views about drug use, depending on based on county vulnerability. And the jury is still out. This is one of the questions she's asking, is the fact that the CDC says your county is highly vulnerable to outbreaks of HIV or HCV due to substance use. Does that change your thinking about the nature of substance use and the politics behind it? Not sure. These are questions like political scientists are starting to ask now, at least in the context of the substance use stuff I'm talking about. But again, this is another appeal for sort of multidisciplinary input, because this is the province of political scientists who could answer these questions for us.
Sandra, you want to go?
Yes, so I am in the epidemiology program at NYU Langone, and I am very interested in the topic. And I wanted to take the opportunity as well to ask you another question, given your expertise in global health and also researching drug abuse. Some of the articles were written at the beginning of the pandemic, the ones that we read for today. And since then, the evidence, the policies and guidelines have changed potentially. So I also think that we must not overlook the potential long-term damages to health of lockdowns, irrespective of the consequences from, lower GDP, unemployment, and economic distress. In other words, in addition to a market versus lives trade-off conversation, we also should look at lives versus lives conversation, where indirectly we gauge also quality of life lost to living in isolation or in the household, for instance, based on the higher repression rates potentially during the pandemic, higher drug abuse, domestic violence, and other cause-specific mortality due to overdose or potential accelerated obesity rates during the pandemic in developed countries. Now, in developing countries, poverty rates could also be prone to increase as well. Particularly worrisome could be poverty rates in children. Most surprisingly, what I found in the past months to weeks, that Dr. Tedros, director from the WHO, and other WHO members have recently mentioned that lockdowns are not a long-term solution for any country. I am assuming particularly emphasizing more they wanted to emphasize more the in reinforcement of testing and contact tracing. So in your opinion, do we have enough evidence as of today to recommend further lockdowns? There are some studies conducted in the US and other developed countries suggesting beneficial effects, but do we have evidence how these would affect developing countries?
So I don't know. So I don't know about developing countries, but what's interesting is that some friends of mine looked at data here about mobility, like looking at travel over the course of the epidemic, and the timing of lockdown orders and relaxation of lockdown orders. People vote with their feet. Like even in southern states in the US who locked down late, people are already limiting social interactions way before, like Governor Ducey in Arizona or Governor DeSantis shut down Florida or Arizona. So some of the government policies are, all well and good, but they in terms of public impact, often not had much of an effect. There's a study that came out a couple of days ago that said, I can't remember how many excess deaths have been in the United States since the beginning of the pandemic. I think the salient piece here is that 2/3 of them are COVID related. The other third are these other excess deaths. And so we know this from other pandemics. School closures in the context of influenza have all these other bad downstream effects. I don't think it's a question of suggesting that the epidemic control has not had these sort of untoward effects that have nothing to do with the virus. The big nasty debate happening right now has been under this idea that lockdowns need to go away forever. They have no role in the pandemic. If we scale up contact tracing testing, if we had 30,000 tests happening a week in the United States rather than 7 million a week, all of us on this call could be tested every 3 days, right? We wouldn't need to lock down because we know where our epidemic was, right? So lockdowns are like a blunt instrument. If we were better at understanding the local epidemiology of our pandemics, we could target isolating groups of people or shutting down certain services for short periods of time. The lockdowns across the board, like we saw in Wuhan in the early days of the epidemic, are unlikely to happen in many places around the world. 8 months later, we can do much better than sort of these blunt force treatments. And I don't think we're going to see many of them in the United States like that. I think we're going to see targeted sorts of measures, particularly if we can get access to more tests, more PPE, et cetera, to make our lives easier. Right now, we do lockdowns because we didn't have much else to do because we didn't have resources forthcoming from the federal government.
Thank you.